I'd like to welcome you to this edition of the award-winning PRS Journal Club podcast with your hosts, Drs. Francesco Egro, Nicole Phillips, and Ira Savetsky. Enjoy.
Good afternoon, and welcome to the May 2018 PRS Journal Club podcast. I'm Nicole Phillips, PRS Resident Ambassador from the Harvard Plastic Surgery Program, and I am joined, as always, by my co-resident ambassadors, Francesco Egro from the University of Pittsburgh and Ira Savetsky from NYU. This month, our guest moderator is Dr. Vu Nguyen, Assistant Professor of Plastic Surgery at the University of Pittsburgh, where he also serves as the Residency Program Director. We are so thankful to faculty members like Dr. Nguyen who allow these conversations to be possible. Thank you so much for joining us today.
Thank you for involving me.
I'd like to briefly remind our listeners that every article we discuss for these monthly podcasts are available for free online. You can find them on the PRS website, along with the article and video pairings selected to complement these discussions. The article we will be looking at next is entitled The Cost of Contralateral Prophylactic Mastectomy in Women with Unilateral Breast Cancer. This is a paper by Billig et al. Out of the University of Michigan with Dr. Momo as senior author. I will admit that I was initially drawn to this article by its title. There are so many ways in which we could calculate cost when used in this context. What is the cost to the patient physiologically and psychologically when both breasts are removed but only one breast has cancer? What is the cost to the surgeon whose operating time and assumed level of risk is increased? If the surgeon is spending more time in the OR dealing with contralateral procedures, what are the downstream effects with other patients in regard to scheduling their procedures and clinic visits? So what is the cost to those patients? What is the cost of the healthcare system? And are the potential benefits enough to offset these costs? Obviously, these questions would be too much for one study to address, but this is why I was intrigued. As a side note, some of the selected article pairings do look at aspects of the equation that are not focused on in this paper, so again I encourage our listeners to explore the PRS website if they are also curious about this topic. To concentrate on the article at hand, this study was designed to examine the financial implications of contralateral prophylactic mastectomy with immediate breast reconstruction. This is a particularly timely study, as the rate of contralateral prophylactic mastectomy has more than doubled in the past 10 years. The authors designed a retrospective study using data from the Truven MarketScan research databases, looking at patients who underwent unilateral versus bilateral procedures for a diagnosis of unilateral malignancy. It is important to highlight that previous studies have examined the cost expenditure and savings associated with contralateral prophylactic mastectomy alone, revealing, as expected, higher short-term costs associated with contralateral prophylactic mastectomy, but potential savings with decreased long-term surveillance. The specific angle of this article was the additional factor of immediate breast reconstruction as a part of the procedure, and whether or not this factor significantly impacted cost analyses. Over 2,300 patients were identified over a 5-year period. These patients had been diagnosed with early-stage unilateral breast cancer. Approximately half of these patients underwent unilateral mastectomy with immediate breast reconstruction. The other half opted for bilateral mastectomies with immediate breast reconstruction. Both autologous and implant-based reconstructions were performed. Index procedure costs were examined, as were the cumulative costs of care over an 18-month period. Cumulative costs included the cost of all procedures, including the index procedure, clinic visits, complications, ER visits, and readmissions. Complication rates were also compared between the two study groups. Although there was a trend towards higher complication rates in the contralateral prophylactic mastectomy group, these trends did not reach statistical significance. Higher costs were associated with both the index procedure as well as cumulative care costs for patients who elected contralateral prophylactic mastectomy versus unilateral treatment. Higher costs were also associated with autologous versus implant-based reconstruction. Interestingly, patients in the contralateral prophylactic mastectomy group were found to have fewer clinic and ER visits than patients in the unilateral treatment group. So this means that the higher costs associated with care of patients in the prophylactic mastectomy group were higher largely due to the increased cost of their index and secondary procedures, and that these differences in costs were significant enough to outweigh lower utilization of clinic and ED resources. In an era where healthcare dollars are increasingly scrutinized, studies like this are likely to play an important role in ongoing discussions of healthcare policy and insurance coverage. Of course, many of the reasons why patients opt for contralateral prophylactic mastectomy cannot be captured in a study designed to look purely at dollars spent. Many patients select contralateral procedures citing peace of mind, improved symmetry and aesthetic outcomes, and the expected improvement in quality of life associated with these factors. This study also did not examine long-term surveillance costs, and it would be interesting to see if the higher expenditure associated with prophylactic mastectomies and immediate breast reconstruction play out over the lifetime of the patient. There are almost no other areas of the body in which we routinely consider contralateral prophylactic procedures. And so I think this is an important ongoing conversation to have with both our patients and with our oncologic colleagues. A question that I was particularly interested in, which was not addressed in this paper, is which site developed complications in the prophylactic mastectomy group. Should we be comparing overall rates of complications between treatment groups, as the authors of this paper did, or should we look at the prophylactic side differently than the side which required cancer treatment? This is potentially another consideration when analyzing costs of contralateral prophylactic mastectomy. We have to think about not just the financial costs associated with the procedures and the associated care, but also the physical and psychological costs of a complication on the side which did not necessarily require surgery in the first place. These are really complex questions. The answers will almost certainly be different for each individual patient, but I'm excited to see them addressed in the journal, and I'm looking forward to our discussion here today. Dr. Nguyen, our patients frequently ask us for advice as they move forward through their breast cancer treatment. What do you think the role should be for plastic surgeons in terms of advising patients about prophylactic mastectomies?
I think this paper really addresses a really critical issue because patients are really looking for guidance when they're in this situation with an active cancer diagnosis and making some critical decisions under a critical time period. While it oftentimes feels uncomfortable to have your reconstruction, somewhat in a retrograde manner, dictate the cancer care, it's interesting how many patients come in with either preconceived ideas, maybe even false information garnered from the internet or even garnered from other sources in regards to what their reconstruction should entail and their decision factors based upon that reconstruction. So oftentimes we're in a situation with educating the patient in regards to what they will lose in choosing the difference between breast conservation therapy and mastectomy, and in choosing between mastectomy and contralateral prophylactic mastectomy. Many patients aren't aware of the loss of the nipple and the areola. They aren't aware of the loss of sensation. And the vast majority aren't aware of the magnitude of the reconstructive time, recovery, and risk in direct comparison to the oncologic treatment, which undoubtedly the oncologic surgery is the most important and critical factor, but it is oftentimes the shortest and the smallest surgery, when instead they're looking at multiple stages of reconstruction prolonged over several months, if not a year or more. So it's inherent upon us to really educate them on this process, which not every patient is capable of going through, and that's why there are options in regards to delayed reconstruction and a whole myriad of different reconstructive types. So it ends up being, like you said, a very collaborative and a very almost intimate decision-making process to inform them and help counsel them on what the available options are, which in the end, in our current environment, patients are still allowed the luxury of choosing what they think is best for them.
You just brought up so many really important points. And one of the things that we have had sort of drilled into us by one of our attendings here is, you always have to start the conversation by saying, listen, you don't have to have any reconstruction at all. A lot of times there's sort of just filter that automatically happens, like you go right from the breast surgeon to our office. And sometimes we're the first person that said to somebody, you don't have to do this if you don't want to. So I think having these conversations and letting people know about all their different options and sort of what's associated with each one is really just such a key part of the process. Francesco, what were your thoughts on this paper?
I thought this was a good paper with a good cost analysis, but honestly, I'm not surprised of the results that the cost of patients undergoing contralateral mastectomy is higher because, after all, they are undergoing a second procedure. What I found interesting, though, is the discrepancy between reconstruction type, specifically how the cost of unilateral implant-based reconstruction is comparable to the reconstruction of contralateral mastectomy. And Dr. Nguyen, I know this paper focused on the financial aspect of contralateral mastectomy reconstruction, but I wonder what are some considerations that one has to make when reconstructing a unilateral versus a bilateral mastectomy defect to ensure optimal aesthetic outcomes?
In the end, from a patient point of view, it's really about being symmetrical. And so when judging unilateral versus bilateral mastectomy, many patients, for example, come in with the notion that they need a bilateral mastectomy in order to undergo bilateral reconstruction for symmetry purposes. And so it becomes, again, an educational process where you discuss with them that symmetry is possible via either route, unilateral mastectomy and reconstruction, particularly if they undergo a contralateral matching procedure, or going the route of bilateral mastectomy and bilateral reconstruction. But while they, in the end, may achieve some element of symmetry, those pathways are different, obviously, in regards to both what they keep and or what they lose, and also in regards to the amount of surgery and the exposure to risk. So again, it becomes a situation of discussing these multiple different pathways that they can go down and having them ideally choose what is best for them. Oftentimes, patients tend to gravitate towards particular decisions for very personal factors based upon family, based upon work, based upon personal or family history of cancer. And so it ends up being a very interesting process to walk them through this.
Thank you so much, Dr. Nguyen, for these great comments. Ira, what were your thoughts about the paper?
I thought this was a really interesting study and very surreal. As a whole, I think prophylactic mastectomies have sort of become more public, especially after Angelina Jolie came out with it. It's just sort of everywhere, and I think it just has more widespread attention. As we know, and as the study highlighted, there's a tremendous financial burden of the healthcare system in general in the United States, and there's no doubt that we're moving towards a more value-based healthcare and bundling of payments. And as plastic surgeons, we often perform surgeries that may not be deemed medically necessary, meaning the patient will not die from not having reconstructive procedures such as breast reconstruction. However, as we know, there's a tremendous improvement in the quality of life. And it may be difficult for policymakers to fully grasp this, and which is why it's important for us as physicians and surgeons to have a presence advocating for our specialty and for our patients. Dr. Nguyen, I guess my question is, I know ASPS has the Plasti PAC ways to get involved in terms of having a voice in government and to make sure that we're advocating for our patients. What are some of the things that we could do to make sure that our patients are sort of getting the best care and have the best quality of life?
I think it's a really delicate question. We have data now and obviously data that will come out in the future that will look at cost and look at outcomes. And much of that for breast reconstruction is a little muddled. You'll have data that sits on both sides of that fence. In the end, I think what we need to do from a practicing standpoint and from a patient standpoint is really preserve choice. In these situations where outcomes can be a little bit muddled and there is not a clear delineated best outcome, I think in that situation, particularly when you're dealing with issues of cancer, recurrence, and quality of life, you have to preserve choice on the side of the patient to be able to choose amongst a group of options that they think is really best for them, because it's not really so far to say that every cancer is different and every patient is different and that every patient's approach to their cancer can be different.
It's a really great point. Just getting back to what we sort of had spoken to a little earlier, and it's about sort of mainly managing patients' expectations. I think oftentimes patients come into the office thinking that breast reconstruction is breast augmentation, and we sort of always have to dial it back and go over things to explain that, oftentimes the goal is for patients to look normal while they're wearing clothing, or quote-unquote normal. What are some of the counseling techniques, or what type of discussion do you have sort of on that initial visit to sort of break it down for them from the beginning?
How much time do you have? So those can be long discussions, obviously, with the patients, and you can carry them out as long as you think the patients can tolerate that information intake, and recognizing that no patient remembers greater than 50% of what you tell them verbally. I think you hit it on the head in regards to talking about what is their goal, and oftentimes that goal is to be symmetrical and be in clothing, and with clothing and the benefit of support, being satisfied with that reconstruction. It is interesting how that oftentimes transforms once they are cancer-free and they are healthy, and they're no longer focused on, I have cancer, but focused on their reconstruction. For better or worse, they oftentimes have a more elevated goal in regards to how do I look in front of a mirror without clothing and without support for myself and for my significant other. I think that's, in this day and age, a perfectly reasonable situation. So oftentimes when you're counseling these patients, you discuss those different levels of goals and recognizing that those things can change over time, particularly over a prolonged period of time as people get farther and farther away from their cancer diagnosis. And obviously, the higher level of symmetry you're looking for, that can require additional operations. And we do have the luxury of having patients drive that process. And it becomes really interesting how some patients can be very comfortable with what we'd consider a reasonable or a good reconstruction, while other patients will drive that process into multiple operations for what we would also consider minor differences in symmetry.
And that becomes very interesting, especially when we're talking about cost and being cost effective. It does become sort of an interesting question and debate. Thank you so much for your comments.
Yeah, I'd like to thank everyone as well. I think this has been a great discussion. Obviously, this is a really rich topic. We could go on for a long time. And the authors of this paper point out in the paper itself how many different questions are sort of bundled up in this particular topic. Certainly looking forward to future studies taking a look at those. I want to end with a message to our listeners to please make sure you remember to check out the other 2 May 2018 PRS Journal Club podcasts. And if you like what you hear, share us with your colleagues and rate us in the Apple iTunes store. If you haven't already, please go to the PRS Facebook page, make sure to like that page, and join us there for our monthly online journal club where you can interact with each month's featured authors in real time. Thanks again, Dr. Nguyen, for all your help today and for a great discussion.
No, thank you.